Dear EDIC aspirants, I am again here with another set of questions pertaining to EDIC Part 1. Welcome to Essentials of Acute, Emergency, and Critical Care. In today's video we will discuss newer advances in critical care and many more. Let's begin. Question 1. A 58-year-old man develops severe ARDS secondary to pneumonia. Despite optimal lung protective ventilation, his oxygenation remains poor. He is being classified as having a hyperinflammatory ARDS phenotype. Which of the following characteristics is most likely associated with this phenotype? Higher plasma IL-6 and lower TNF-alpha concentrations. B. Lower vasopressor requirements and mortality. C. Increased benefit from higher PEEP strategies in secondary analyses. D. Reduced endothelial injury markers. Lower prevalence of shock. Correct answer is C. Increased benefit from higher PEEP strategies in secondary analyses. Explanation. Recent ARDS research has identified two major biological phenotypes: hyperinflammatory phenotype and hypoinflammatory phenotype. The hyperinflammatory phenotype is characterized by elevated IL-6, IL-8, TNF receptor 1, more shock, higher vasopressor requirements, higher mortality, more endothelial injury. In secondary analyses of landmark ARDS trials, such as alveoli, patients with the hyperinflammatory phenotype demonstrated a significant reduction in mortality and more ventilator-free days when managed with higher positive and expiratory pressure strategies. In contrast, the hypoinflammatory phenotype showed worse outcomes with higher PEEP. Question 2. A patient presents with septic shock. Lactate is 5.2 millimole per liter after adequate fluid resuscitation. Norepinephrine is required to maintain MAP greater than or equal to 65 millimeters of mercury. According to sepsis 3 definitions, which criterion is mandatory for septic shock diagnosis? Lactate greater than 2 millimole per liter. B. Vasopressor requirement. C. SOFA increase greater than equal to 2 alone. D. Both vasopressor requirement and lactate greater than 2 millimole per liter despite adequate resuscitation. E. Positive blood culture. Correct answer is both vasopressor requirement and lactate greater than 2 millimole per liter despite adequate resuscitation. Explanation. Under the updated Third International Consensus definitions for sepsis and septic shock, sepsis 3, septic shock is specifically classified as a subset of sepsis in which underlying circulatory, cellular, and metabolic abnormalities are profound enough to significantly increase mortality. To be diagnosed with septic shock, a patient must meet both of the following criteria despite adequate volume resuscitation. 1. Persistent hypotension requiring vasopressors, norepinephrine, to maintain a mean arterial pressure equal to or greater than 65 millimeters of mercury. 2. A serum lactate level greater than 2 millimole per liter, which indicates underlying cellular and metabolic dysfunction, such as tissue hypoperfusion or aerobic glycolysis. Question 3. A 70-year-old patient presents with septic shock. Initial fluid resuscitation has begun. According to current evidence and surviving sepsis campaign recommendations, which statement is most accurate? Vasopressors should never be started through peripheral access. B. Norepinephrine should be delayed until 30 milliliters per kilogram fluids are completed. C. Early norepinephrine administration may improve achievement of target map and reduce fluid overload. D. Dopamine is preferred in elderly patients. Vasopressin should be first-line vasopressor. Correct answer is C. Early norepinephrine administration may improve achievement of target map and reduce fluid overload. Explanation: administering norepinephrine early in the resuscitation phase, even before the completion of the 30 milliliters per kilogram fluid bolus, is now encouraged. It counteracts sepsis-induced venous dilation, which moves blood from unstressed to stressed volumes, quickly restoring the mean arterial pressure and preventing dangerous fluid overload. Vasopressors can, and frequently should, be started through a secure peripheral intravenous access to prevent dangerous delays while waiting for central venous access. Norepinephrine remains the definitive first-line vasopressor. Vasopressin is only used as a second-line agent, typically added to spare norepinephrine doses when MAP targets are not met. Question 4. A mechanically ventilated septic patient is admitted to ICU. Current ESPEN recommendations suggest which approach? Full caloric feeding with 24 to 48 hours. B. TPN after 72 hours. C. Gradual advancement of enteral nutrition during first week. D. Caloric intake 30 to 35 kilocalorie per kilogram of body weight per day. E. Low caloric feed. Correct answer is C. Gradual advancement of enteral nutrition during first week. Explanation: enteral nutrition should be started early, within the first 24 to 48 hours of ICU admission. Rather than immediately hitting full caloric and protein targets, which carries the risk of overfeeding, nutrition should be initiated at a low dose, trophic feeds, and progressively advance to meet energy targets over the first week. During the acute, initial phase of critical illness, ESPEN advises avoiding energy supplies in excess of 20 to 25 kilocalorie per kilogram of body weight per day. Question 5. A patient develops VP due to carbapenem-resistant Klebsiella pneumoniae producing KPC carbapenemase. Which antibiotic is generally preferred when susceptible? Colistin. B. Tigecycline. C. Meropenem. D. Ceftazidime-avibactam. E. Ceftriaxone. Correct answers: Ceftazidime-avibactam. Explanation: Ceftazidime-avibactam effectively neutralizes the KPC enzyme. It is the recommended first-line agent, often outperforming older, last-resort drugs in both mortality reduction and nephrotoxicity. Colistin and tigecycline are older salvage therapy or rescue agents. While useful for extensively drug-resistant bacteria, they are significantly more toxic, higher rates of nephrotoxicity with colistin, and have historically shown poorer clinical response rates in severe pneumonias. 4 KPC-producing enterobacterals. Other preferred newer agents include Meropenem-vaborbactam and Imipenem-relebactam. Question 6. A patient with septic shock remains hypotensive despite fluids. Which variable is currently considered the best indicator of tissue hypoperfusion resolution? CVP normalization. B. SCVO2 greater than 70%. C. Lactate clearance trend. D. Urine sodium. E. Mean arterial pressure. Correct answer is lactate clearance trend. Explanation. In managing septic shock, normalizing tissue perfusion is the primary goal. While mean arterial pressure should be optimized, it is a measure of pressure rather than a direct indicator of tissue-level perfusion. Serum lactate is a direct biochemical marker of anaerobic metabolism due to tissue hypoperfusion. Serial measurements showing a consistent downward trend, for example equal to or greater than 10% clearance within 2 to 4 hours, serve as the most reliable indicator that tissue perfusion and oxygen utilization are improving. Central venous oxygen saturation is a useful surrogate for the balance between systemic oxygen delivery and consumption, but it can be artificially elevated or normal in sepsis due to microcirculatory shunting. It is considered complementary to lactate, not superior. Andromeda shock has also highlighted capillary refill time as a valuable endpoint. Question 7. Which biomarker combination is FDA approved to predict risk of AKI in critically ill patients? NGEL plus cystatin C. B. IL-6 plus CRP. C. TIMP-2 plus IGF-BP7. D. Procalcitonin plus lactate. Endocrine plus Percepsin. Correct answer is TIMP-2 plus IGF-BP7. Explanation. The urinary combination of tissue inhibitor of metalloproteinases 2, TIMP-2, and insulin-like growth factor binding protein 7, IGF-BP7, was the first biomarker panel FDA approved for assessing the risk of moderate to severe acute kidney injury, AKI, in critically ill patients. Sold under the trade name NephroCheck, it specifically measures these markers of G1 cell cycle arrest to predict impending kidney stress 12 hours before clinical manifestation. Question 8. Which statement regarding procalcitonin is most accurate? It reliably distinguishes bacterial from fungal infection. B. It should be used alone to start antibiotics. C. It can support earlier discontinuation of antibiotics in selected ICU patients. It is superior to clinical judgment for diagnosing sepsis. It is unaffected by renal dysfunction. Correct answer is It can support earlier discontinuation of antibiotics in selected ICU patients. Explanation. Procalcitonin algorithms, which utilize serial measurements to track declining PCT levels, often an 80% drop from peak or levels falling below 0.5 nanogram per milliliter, are heavily supported in the ICU to shorten the duration of antibiotic therapy without compromising patient safety or survival. While PCT is highly useful for differentiating bacterial from viral infections, it is not reliable for perfectly distinguishing between bacterial and fungal infections. Procalcitonin should never be used alone to initiate antibiotics. Treatment decisions must always incorporate careful clinical judgment. Procalcitonin levels are frequently affected by renal dysfunction. Both chronic kidney disease, CKD, and acute kidney injury, AKI, can impair PCT clearance and elevate baseline levels, making diagnostic thresholds for infection in these patients much harder to interpret. Question 9. A ventilated septic shock patient receives multiple fluid boluses. Which method currently has the strongest evidence for predicting fluid responsiveness? Central venous pressure. B. Pulmonary artery occlusion pressure. C. Inferior vena cava diameter alone. D. Passive leg raising with real-time stroke volume measurement. E. Mean arterial pressure. Correct answer is B. Passive leg raising with real-time stroke volume measurement. Explanation. Dynamic tests that use provocative maneuvers to challenge the heart, like a passive leg raise, paired with real-time cardiac output or stroke volume measurements have the strongest evidence and highest sensitivity and specificity for predicting fluid responsiveness in shock. This maneuver acts as an endogenous fluid challenge, autotransfusing about 200 to 300 milliliters of blood from the legs into the central circulation. It is fully reversible. Because blood pressure can be misleading, evaluating hemodynamic response relies on real-time stroke volume changes, usually an increase of greater than 10%, using technologies like echocardiography, pulse contour analysis, or bioreactance. Question 10. A 46-year-old man is admitted with severe community-acquired pneumonia. After 24 hours of optimal management, his ventilator settings and investigations are: volume-controlled ventilation, tidal volume, 6 milliliters per kilogram predicted body weight, respiratory rate, 28 per minute, FiO2, 0.80, PEEP, 14 centimeters H2O, plateau pressure, 28 centimeters H2O, driving pressure, 14 centimeters H2O, O2, 62 millimeters of mercury, CO2, 52 millimeters of mercury, pH, 7.31. The patient is deeply sedated and receiving cisatracurium infusion. Echocardiography shows no significant right ventricular dysfunction. Which intervention has the strongest evidence for reducing mortality if implemented now? Increase tidal volume to 8 milliliters per kilogram predicted body weight to improve oxygenation. B. Initiate inhaled nitric oxide. C. Perform prolonged prone positioning sessions. B. Initiate routine recruitment maneuvers followed by decremental PEEP titration. B. Initiate venovenous ECMO immediately. Correct answer is C. Perform prolonged prone positioning sessions. Explanation. The PROSEVA trial demonstrated that early application of prone positioning for at least 16 hours daily in patients with severe ARDS, like this one, with PF ratio 77.5 and oxygen concentration 60% or more, significantly decreases 28-day and 90-day mortality. A higher tidal volume increases the risk of ventilator-induced lung injury, valatrauma, and barotrauma. Lung protective ventilation, 4 to 8 milliliters per kg, is standard for ARDS. While inhaled nitric oxide transiently improves oxygenation, multiple systematic reviews, including Cochrane Database of Systematic Reviews, show that it does not reduce mortality and may increase the risk of renal impairment. Although ECMO is used for refractory hypoxemia, it is typically considered a rescue therapy when conventional, less invasive measures like proning fail to stabilize the patient. Dear doctors, this is the end of this video. I understand you may be having some doubts that you can ask me by writing in comments section. See you soon with another set of questions. Till then, bye and take care.